I'll be speaking mostly on the practical aspects of management rather than what's already available in the literature. Yes. So how many here do actually manage a diabetic macular edema so that I know what I am speaking to? I think the the girls at the back, are you PG students? Yes.
Warangal.
Yeah, so there's hardly anybody here who's going to manage diabetic macular edema.
Let them
They
learn.
might become retina specialists, you never know.
Yeah. Yeah, you are already. I don't need to.
Mallika,
Yeah.
AIOS conferences, you don't have to look there. You look at your talk is being recorded and it is available on
Okay.
YouTube.
Oh, okay, great. That's a
Okay,
good point.
so you go.
Thanks.
Everybody will listen.
Okay, great. So we'll speak about management of diabetic macular edema. The basic principle remains good systemic control of blood sugar, blood pressure, serum lipids, anemia, renal status. This is the foundation. And this can show results within 6 weeks. And following this only is the serial anti-VEGF injections, which are the first line ocular therapy. Laser, intravitreal steroids, and vitrectomy have only secondary roles in particular cases. So when we see a patient of diabetic macular edema, only the one which is in the white square, that is the area which we treat, which is center involving diabetic macular edema with visual reduction. If the vision is better than 20 by 32 uh, and there is very mild edema, this can be left alone and left under observation. Can you stop this photographs? Thanks. On the other hand, if the edema is not involving the center, then this can go be treated with focal laser if required, and that should be enough. Now, it was only in 2008 that we first started seeing excellent visual recovery with treatment, which was with anti-VEGF agents such as ranibizumab. Before this, only laser was available, which was not showing improvement in vision, but only stabilization of vision. Following ranibizumab showing improvement, we had aflibercept coming in, which showed that not only vision improves compared to laser, where 11 letters with aflibercept and not even 1 letter improvement with laser, but also aflibercept was able to, I'm sorry, this animation is not working, but also aflibercept was able to uh, increase the treatment interval to 2 months from 1 month with the same results. So then we had newer and newer agents with longer duration of action so that fewer injections were required. In India, we now have faricimab, which allows injection every 4 months in up to 60% of the patients. And now we are expecting Eylea high dose, which is 8 mg aflibercept, which will allow 4 monthly injections in 90% of the patients. So this is a big relief and reduced treatment burden. So to intravitreal injection, these are the options which we have already discussed. In addition, there is steroids, triamcinolone acetonide or dexamethasone implant. The protocol of treatment, now we do not treat patients who have reasonably good vision and very mild edema. Some fluid can be ignored if vision is good, because there is no benefit to treatment as has been found in the recent studies. So just observe these patients. Earlier we used to treat these patients, but now we do not treat them. The current protocol is if vision is less than 20 by 32, we treat with monthly injections for 6 injections, and then at the end of 6th month, if there is persistent macular edema, we take the patient for laser. However, we can stop the injections before 6 if the vision is improved and the edema is negligible, or if in the last 2 injections there is no further change in vision or edema status. Continue injections if there is, even beyond 6 injections, if there is any improvement in the last 2 injections, and stop if it is stable, but restart as soon as you see worsening of edema or visual acuity. The mere presence of some fluid at macula is not an indication for treatment. When we say worsening or improvement, we mean a minimum 5-letter change or a 1 Snellen line visual change, or a minimum of 10% central subfoveal thickness change on OCT. Now, why do we give 6 injections instead of 3? is when we stop at 3, we have 52% of eyes that have persistent edema. But going to 6 injections, it reduces to only 32% of the eyes that have persistent edema, with further 3-letter improvement in vision. Which anti-VEGF to be used? The landmark trial was the protocol T, which showed us that in the overall group of patients, there is no difference whether you use ranibizumab or aflibercept, but in those that have significantly poor vision, there aflibercept gave a better response at 1 year, but by the end of 2 years, ranibizumab and aflibercept gave similar response. However, Avastin or bevacizumab continued to perform poorly, with persistent DME more likely with this drug. So in summary, in eyes with more severe macular edema or poorer vision, aflibercept or one of these stronger drugs may have a better response than ranibizumab, at least at 1 year. The other concept which has come up is that prompt treatment is much better than delaying the treatment. If you delay the treatment by 2 years, then giving injections even monthly, you get only a 4.5 letter gain compared to 11 letter gain if you had started right at presentation. So prompt treatment is also important. Now, how long do we need to give these injections? Unlike AMD, these injections can be reduced significantly after the first year. Up to 20 to 30% of the patients do not need injections even in the second year, and almost no patient may need after the third year, without losing the benefit, the visual benefits that they got in the first year. The only problem with stopping injections is that there is the very high risk of progression to proliferative diabetic retinopathy when anti-VEGF dosing is reduced. Contralateral eye often benefits, so check the patient before injecting. We may not need injection in the other eye. There is no benefit found to giving injection. I'm sorry about the animation. Okay. There's no benefit found to treating the non-perfusion peripheral areas as regards number of injections or reduced or improved visual acuity. Macular exudates, very important. Once they come, they are very resistant to treatment and they lead to permanent vision loss. So the treatment involves systemic control, injections and laser. This is a patient who was very non-compliant with very high lipid profile, and over 1.5 years significant deterioration, but within 6 months, once he agreed to periodic injections and systemic control, you can see the improvement with vision also. Another lady continued to deteriorate with widely spaced injections, but once we controlled her systemic disease and the injections, you can see that now the lipids have resolved, edema has resolved, and there's no further injections required in the last 1 year. And no laser was required, no steroid was injected. Similarly, other patients, here you can see that the lipids have resolved, but the vision has actually deteriorated because of the lipids at the macula. So that is why it is very important to prevent foveal involvement rather than chase it once it has come. Intravitreal steroids can be used even after vitrectomy. They have intravitreal steroids have a long duration of action, but even the newer anti-VEGF agents have a comparable duration of action where the IOP rise is seen following steroid injection. Laser is recommended for eyes with persistent cystoid macular edema, diabetic macular edema, and it improves the long-term outcome, which may be required in up to 40 to 60% of the patients following injections because they continue to have persistent macular edema. To do a laser, we need an angiography, which should be separated from an injection by at least 3 days because they may interact, the fluorescein and the intravitreal injection. And once the macular thickening has reduced, about 4 weeks later, laser is done. The role of steroids in DME is for persistent macular edema which doesn't respond to anti-VEGF agents, or when there is a planned cataract surgery where it covers the inflammatory component, and where anti-VEGFs are contraindicated due to pregnancy, recent cerebrovascular events and severe renal disease. Problem with steroids being cataract and intraocular pressure elevation, so contraindicated in glaucoma and immunocompromised patients. Also, dexamethasone should not be injected in patients with large PC opening or a scleral fixated IOL. This is my own patient where it migrated into the anterior chamber, causing corneal decompensation. Imaging, how much time do I have? Yeah, okay.
Need to conclude.
Okay. Fluorescein angiography continues to have a role because it tells us the diagnosis. Here we might think it is diabetic maculopathy, but this FFA shows that it is BRVO, and it shows us the area of leakage where we need to treat. As in this patient, fluorescein is showing us the area of leakage, the arrow, where we need to do the laser, which cannot be shown by the OCT angiography. Fluorescein also picks up new vessels in hazy media, which OCT angio cannot. And surgical intervention, Dr. Babu will be speaking, but generally related only if there is a traction. Many times we find that just with injection or with scatter laser, the macular traction has been released and surgery is not required. So there should not be any undue hurry towards surgery. However, some cases, as you see before and after surgery, they respond to injections only after surgery. And some patients never respond, but we need to treat just to prevent worsening. DME worsens following cataract and glaucoma surgery, so should be treated before the surgery, or at least at the end of surgery an injection should be given. And the last point about NSA drops for DME has been found to be of no use in the management of DME, but we do use it for DME prophylaxis following scatter laser and cataract surgery. Thank you.